In this video, we will discuss about clinical application of knowledge of occlusion in general dental practice while doing routine dentistry using conformative approach. Application of occlusion can be used in multiple ways in general dental practice. It can be used when you're fitting or preparing single or multiple restoration while treating patient using conformative approach. It can be used for fabrication of splints, treating minor temporomandibular disorders such as using Michigan splints or anterior positioning appliance. Understanding in assessing occlusion would prevent general dental practitioner treating some of the cases which can then cause problems later on, such as if patient has a large horizontal, small vertical slide from CO to MIP. However, when you have assessed this beforehand, and if you have a knowledge of it, you will be able to treat this case more predictably and easily. It will also help you in doing simple implant restoration by managing guidance appropriately. So let's look at some of the clinical uses of and practical steps you can use in general dental practice. So one of the common treatment we perform in general dental practice is direct restoration. So let's look at how occlusion can help, or knowledge of occlusion can help when you're doing direct restoration. So I would recommend when you are assessing contact points, use 12 to 14 micron thick articulating paper. There are various sizes of articulating papers available. The thinnest you can get is around 12 micron because it's an 8 micron sheet, and then you have color which has a certain thickness. You could get a single surface articulating paper which is thinner than a double surface articulating paper. However, I tend to use double surface articulating paper which is with a 12 micron thickness, which is appropriate for the routine dentistry. Check the contacts before you start removing caries, and this is very important. Many times we see caries and we just want to get rid of it, clean it, and start restoring the tooth. However, make sure that if the tooth is got some anatomy present, if you're doing conformative approach, you could take an index of that tooth to help you in replicating that anatomy, but also make sure you check the contacts of either side of the teeth using shim stock and articulating paper, but also the contacts on the same tooth which you're preparing for restoration, because that will help you visualizing your end result. And that leads to our next point, that make sure that you visualize the end result of your restoration and the occlusal height by direct vision, by checking directly in patient's mouth and checking the occlusal contact points and seeing where the teeth are contacting. Learn morphology of teeth and modify it depending on the adjacent teeth. So with regards to learning about the morphology of the teeth, make sure that you read books, use wax models, and just practice it on the model and see how you can modify anatomy slightly differently in order to fit into existing occlusion. Look at the adjacent teeth and their marginal ridges, because what I've noticed is many times the marginal ridges are the same height. So when you are placing rubber dam and you can't really check the occlusion properly during the restoration, make sure that you use the adjacent tooth as a guide. So I would ask patient to close their teeth before I start restoration and visualize how is the adjacent teeth relate to that, where is my tooth fitting, and I would then start doing the restoration. If you're doing that, then you will reduce your adjustment much more massively. Also, I tend to keep the features slightly deeper, so if I need to do adjustment, then tooth doesn't look really flat. Make sure that when checking occlusion after restoration, check visually first before you start adjusting the tooth. So if you're using articulating paper and you check and you see there's a high point, make sure that you check whether that's the true contact, because if you're using really good articulating paper, one of the disadvantages of that is they mark really easily. So if you're moving articulating paper up and down, it can mark the surfaces which are not really contacting. And once you use them more often, you are able to differentiate which are the true marks than the false marks. But looking in patient's mouth, sometimes it becomes very obvious. So make sure that you look in patient's mouth while checking the occlusion directly. So once you have assessed all this for anterior teeth, one of the other thing you need to understand is make sure that you keep the patient a little bit upright and then check their occlusion, because of the gravity and because of the jaw and muscles, the way it works. When patient sits up, their jaw position changes, and you need to make sure the patient's comfortable in that jaw position. And that's why you probably have seen where you've done adjustment, you checked everything, and patient stands up, rinses their mouth, and said, the tooth feels proud, or the filling feels high. And then you have to put the patient back in again, recline it, and try and adjust it. However, I would say that you keep the patient upright and try and check the contact points first, because sometimes the jaw position moving substantially and you're not aware of it when patient's lying back. So we looked at this case previously where patient had a chipping of upper right central, and this is the finished result where I'll make sure that when patient's guiding, the filling is not in first contact. So when patient's guiding, there's a nice guiding line and the filling contacts later on. I wouldn't mind my adhesive dentistry or adhesive fillings in guiding surfaces, as far as not the only tooth which is guiding. However, if you do a really good adhesive dentistry, which I'm sure you do, you shouldn't need to worry about using a guidance on the same filling or restoration. However, it helps if the guiding starts on the tooth and follows on to your restoration. We didn't end up doing veneer because I convinced patient to do orthodontic treatment later on. Now, if you're looking at occlusion or application of occlusion for single indirect restoration, then the things you need to consider is, again, use of articulating paper, which is 12 to 14 micron thick. And what I was discussing one of the colleague, and we came to conclusion that having a good quality articulating paper is very, very essential for a restorative dentist, along with shim stock. So make sure that you have a really good quality articulating paper where you can assess true contact and you're not reducing contacts. So when you are checking the contacts after you finished your restoration, you want contact on your restoration. So you don't want to just keep grinding the tooth until you lose all your contacts and only the either side of the teeth are in contact. You want the contact in your teeth and you want the contact on the either side of the teeth as well. So you want a distributed load. You don't want just tooth out of contact. Otherwise, there is no point in learning about occlusion. So the other thing you need to understand when you are treating tooth with indirect restoration is, after you've done preparation, don't only check the reduction when patient closes their teeth. Make sure you ask patient to do lateral excursion and check that there is enough space for you to restore the tooth in lateral excursion, because sometimes you can incorporate non-working side contact because the reduction is not enough when patient's doing lateral excursion. So make sure that you have enough reduction when patient's doing lateral excursion. You can choose triple tray versus full arch trays. I always use full arch trays because I usually ask technician to at least mount the models on a hinge articulator rather than just a small hinge articulator of a sectional jaw. However, you can use triple tray if you're not replicating any guidance and you just want the contact points to be stable. However, if you're not using any sort of articulator, then the problem is you might end up incorporating guidance where you don't want to incorporate guidance. So you may need a little bit more adjustment in the mouth when you're using that approach. Use articulator when you would like to incorporate the guidance. So if you're doing anterior case and if I want anterior teeth to be guiding, I would ask technician to mount the model on a semi-adjustable articulator. I always instruct my technician to make sure that the contact point, occlusal contact point on the opposing teeth are not on an inclined plane. So when you two teeth contacts, I don't want the cusp tip to the inclined plane of the cusp tip of the tooth I'm restoring to the inclined plane of the opposing tooth, because it can cause traumatic forces. So you want a flat surface where the upper restoration, if you're treating that, landing the mandibular tooth. Now, what are the steps when you are fitting the indirect restoration? So let's look at the steps. So the step one is make sure that the crown fits on the model. And this is very important because if it doesn't fit on the model, then you need to question whether you want to take the provisional out and what you would like to do. You may want to repeat the impression. However, you may want to check in patient's mouth and compare whether it's the same what's in the patient's mouth than on the model. I tend to ask technician to create a static model, which is the first pour model. So they pour the model first time and keep that separate, and they pour the model again and work on that, and that's called working model. And once that crown is done, they fit it on a static model where the dies are not cut, and make sure they check that it fits. And I want that static model to be delivered with the work so I can assess that technician has done that. And this is very, very important if you want to avoid issues with occlusion and the contact points. Make sure that on the model, the contacts with adjacent teeth are present and crown fit with the die in situ with the model. So what does that mean is make sure that when you fit the crown, the contact points are very good, because unfortunately I've seen sometime where on the model, because of the poor quality control, the technician has removed the contact and the contact is the tooth is out of contact. If the crown is out of contact, you can't really build the contact, so you'll have to send it back to redo the crown or add a porcelain to it. If the contact is very tight, you will probably end up having adjustment done in patient's mouth. So just be prepared for that. Step 3 is in the mouth now, you need to check the shim stock hold and articulating paper hold of the adjacent teeth and make sure that you know where the contact points are. You record it and you make a note of that, because you want that to be replicated after you fit your crown. Also, the crown should have a contact as well, or a guidance if you have planned guidance in that crown. Use articulating paper to check the contact for references on the opposing arch as well. So on the opposing side, so I would check the adjacent teeth on the same side and some of the teeth on the opposing side, because you want to make sure you're checking on the both sides, the contact. I tend to take photos to make sure I memorize it, I know where the contact point is. But sometimes if you just leave those contact points as it is while you're fitting the crown, it helps you in assessing later on. Now seat the crown in the mouth and check if it's seating the same as on the model. If it seats same as on the model, contact points are fine, then great. However, if it doesn't seat the same on the model, so if the marginal fit is not great and the contact points are open or something like that, then you need to really ask a question whether the impression was accurate or not. But let's say if the crown fits fine on the model, but it's not going completely down on the tooth, then make sure that you check the contacts first, because most all the time it's the contact which is too tight, and by adjusting the contact appropriately, you will be able to make the crown seat. So I don't check crown's occlusion until the end, until I'll check the fit of the crown and check to make sure that the contacts are not too tight. So that leads to the step 6. So once you seat the crown and check the contact, even if the margin fit looks okay, if you check the contact, if it's too tight, I would recommend that you put articulating paper in there, push the crown and slide the articulating paper out to check the contact point and adjust that contact point ever so slightly with a red striper burr to make it a little bit lighter. Sometimes you can rub the articulating paper on the floss, ask nurse to hold the crown down and slide the floss down, and that will give you a contact mark where there is a contacting, and you can adjust that contact point. And that is also a helpful tip. But don't progress further until the contact point is not too tight. If the floss is, you have to push really hard, or if floss is tearing, that could be the reason why it could be because the contact is too tight. So make sure you check the contact points first. Sometimes, even if the crown looks, completely seated, and you check the contact and it's a little bit tight, but think the crown is seated, just make sure the contact is light enough, because if the contact is too tight, sometimes crown can wobble and make you look like it's seated properly, but it's not seated properly. So again, checking contact point is really important. Having a technician who takes care in checking contact point in the laboratory will help you a lot of time, chairside time. So this is something, if you have to check, if you have to adjust the contact very frequently, then you need to really ask questions and you need to have a chat with your technician. And again, once you adjust the contact point, check the marginal fit again. Once you've done all these steps, make sure then you check the occlusion where you have occlusal points on your restoration and other teeth. Make sure that you have a contact on occlusal on the tooth crown as well as on the other teeth. You don't want the crown to be out of contact, because you may think, okay, the tooth is weak and I don't want crown to be loaded. Yes, have a lighter contact. However, if you have the crown completely out of contact, the opposite tooth might super erupt anyway, and you end up having the contact later stages. So it's a false sense of security to have the tooth out of contact. Maybe have a lighter contact, but don't have them out of contact. When you're checking the contact, make sure that either side of the teeth are contacting and your restoration is also contacting. Once you've done that, static contact, then check the lateral excursion. And if you have developed a guidance which you've done planning, you need to then reduce the guidance. And you can use the technique we use while doing clinical examination. So you can check the static contact using black articulating paper and the guidance using red articulating paper, and then you just remove the red marks which is not overlapping the black, and that will give you tooth which is in contact in MIP but not contacting during guidance. Make sure that as far as the teeth on either side are present, you don't need to worry about restoring multiple restorations. It's almost the same as treating a single tooth. If you're doing a direct restoration, then make sure you check the occlusion prior to the restorations, as we discussed before. If possible, you can do one restoration at a time. However, if you're doing quadrant dentistry, you don't want to take the rubber dam on and off. you can do all the restorations together, but make sure you check, and it may take a little bit longer for you to assess the occlusion because you want all the teeth in contact. You want teeth which is guiding in guidance with teeth which are not guiding without guidance, but principles are the same. If multiple restorations is done, then you can, as I said, adjust one until all the teeth are in contact same as before, along with the newly restored teeth. So when you're using conformative approach, your adjacent teeth or your existing teeth becomes a guide for you to restore the other teeth. If you have done diagnostic wax up, then that's great. If the current teeth which you're restoring doesn't have too much morphology, where it's big holes or anything like that, you could really take an index of that and use that to replicate the same in your final restoration. For indirect restoration, you check if you have let's say 2 crowns together, or 3 crowns. If you're doing 6 crowns 3 to 3, I would check individually the crown fits fine, check the occlusion, check the contact points of the either side of the teeth if they are present, and make sure that the crowns individually fits fine. And then I would start fitting, I'll put one crown and put another crown next to it and check that the occlusion points and everything is the same. If it's not the same, then it's a contact point between those 2 crowns, which may be pretty tight, and you might have to adjust that. And I cannot stress enough that when you're doing multiple restoration, you really need to learn how to check the contact points, because many times the contact points is ever so slightly tight, but it will not allow you to really see that the crown is not seating properly. And you might have a false sense of security that crown is seating, but by adjusting the contact ever so slightly, you will be able to see that the fitting is much better. But if you have fitted the crown individually, you will be able to see the difference. So try and doing that and assessing one crown at a time, and that really helps in checking that. So these are the practical tips I had for you when you're doing direct or indirect restorations, single or multiple, using conformative approach. Let's look at some of the other scenarios which you might come across in your day-to-day practice. So we looked at this case during our previous treatment planning presentation, where there is a collapsed posterior bite. So there is a super eruption of the 6, and there is lack of space of the 7 on the mandibular tooth. So what are the options here we have? So one of the options is that you reduce down upper left 6 by doing a new crown. The problem is, if you reduce that crown a lot, you may end up exposing the pulp and needing a root canal treatment. If the tooth is already root canal treated, then it becomes a little bit easier to change that crown, but also it's an additional cost to the patient. The other option is you to reduce the upper and lower teeth. If it's a virgin teeth, it's not a crown. If it's a normal tooth, you reduce a little bit of the upper tooth and lower tooth and try and fit the bite. The other option, which is less invasive option, is orthodontic intrusion of the upper tooth. But it is very difficult to do intrusion on its own without having some effect on the lower arch, and that's why you need probably anchors to be able to intrude the tooth, and you need probably orthodontist to be able to do that. Sometimes you can do crown lengthening, or if it's a distal lower tooth, then you can do gingivectomy on the distal aspect by doing a crown lengthening procedure and gain the space. The problem is that until and unless you are making sure that the occlusal plane is parallel and it's not going up and down like that, you are not really solving the problem. And that's why in this particular case, I would prefer to redo the crown on the upper arch and make sure it's on the same occlusal plane as the other teeth, and then redo the lower arch, or obviously orthodontic treatment. And that would be my preferred choices. With regards to the other case where the completely bite has collapsed, in this case where you have maxillary 6 and 7, at least 7 is contacting the occlusal, the edentulous space on the 7 lower, the options are the same. You need to make sure that you either do orthodontic intrusion, or you would do reduction of the maxillary teeth to create some space. You could, if the other teeth are in bad shape, increase the vertical dimension. However, that won't change the fact that the plane is falling down at the back unless you restore just the upper arch. In this case, we ended up doing some adjustment on the 7 and restored the teeth, which with a slight of the curvature, and this is because patient did not want to do orthodontic treatment. And this is the only way we could give patient some fixed teeth. Now, another situation which you can come across is patient when they have single standing tooth or posterior tooth with first point of contact. In this case, we discussed again before, let's say we want to change the gold crown, and that's the first point of contact, so the tooth is in CO. So what are the options you have with this restoration? So one of the options you have, if it's a direct or indirect restoration, is to replicate exactly what patient has in their mouth. So you take an index or a scan and you replicate that same shape, and you would cement the new crown with the same shape. It's a very difficult technique to do, and you need a very high-skilled technician, and you need all the things to go right. Even then, there is a chance that it may not work. And if you have chance to reduce the slide, then this would be, you can take this as an opportunity and do a little bit more reduction on the 7, because you will lose the space, because when you remove the crown, the jaw will close a little bit more, and that will cause the space to reduce. And because of that, you will probably have to do a little bit more reduction. But if you have space, then that's really the best way to deal with this and easiest way to deal with this. However, if you don't have enough space to reduce the tooth more, then the option you have is orthodontic treatment, or try and replicate the contact again, which is, as I said, is tricky. And that's why assessing amount of slide becomes really, really important. So if you are using leaf gauge and assessing the slide like our patient during the clinical examination, if the slide is around 2 mm or 1.5 mm, then you may end up doing around 1 mm reduction, and the jaw just closes onto that tooth, and you just lose all the reduction you've done. So you need to really assess the slide before you start preparing that tooth, in order for you to assess how much reduction you will have to make and warn the patient of the consequences. Now, another case we discussed during the treatment planning is this one, where there was a patient was referred to me with failure of this restoration over and over again. And what we decided, that there was a lack of canine guidance. The lateral was guiding, because as you can see, lower canine was hitting on the lateral, and the premolar was guiding, but they weren't guiding enough for it to disclude really, really well. So this is the occlusal aspect. So let's look at what we can do with the treatment planning. So when you're planning these cases, first thing you need to do is make sure you take upper and lower impressions, use a Facebook registration, and mount the model. You don't need to take a bite registration if the occlusion is stable. If occlusion is not stable, then probably this treatment is not good enough. You probably need to look into more comprehensive treatment, such as at least single arch reconstruction. But in this patient, occlusion was stable. So as far as you can hand articulate the models, you don't need to take a bite registration. Once you mount the model on a semi-adjustable articulator, you assess the occlusion on the articulator and assess the guidance carefully. Once you assess the guidance, you would do diagnostic wax up and replicate the final restoration. In this case, what I've done was I marked the MIP contacts, and for the maxillary teeth, I built the composite incisely to the MIP contact. So I'm not changing the occlusal vertical dimension. I'm not making the, increasing the OVD, but I'm changing the guidance. And this is one of the simple way to do this. You could do this directly. However, there were 3 teeth involved because I wanted to use other teeth on the right hand side to steeper the guidance, because the front 2 teeth were post and core and I didn't want them to guide. So there were 3 teeth involved, and that's why I decided to do the mounted model and use the mounted model and the wax up. So once you have done the wax up, you can then use clear indices, and I use ExoClear from GC, and that's a really great product. Just squeeze some ExoClear on the wax up or on the duplicated model from the wax up, and use that to put the heated composite and place it on the tooth and cure it through that ExoClear material. And that helps in predictably building the guidance without having to adjust it too much, because you already replicated in the mouth. And this is really helpful and very easy to do in general dental practice. So if you look at this case, the mounted model, we did the wax up. In this case, I did wax up myself, because for the smaller cases, I tend to do wax up myself. It gives me better control, and I end up doing the restoration twice, one on the model and one in the mouth, and that gives me better idea how things work. But you don't need to do the wax up yourself if you don't fancy doing that. But by doing the wax up, you learn a lot of things about anatomy, how the patient's jaw work, how the guidance works, and it gives you more confidence. So in the mouth, we place the composite, and as you can see, the guidance are on the natural teeth, and all the post and core teeth are not guiding. And this was the provisional we made, and then patient decided to have something long term on the lateral, so we end up extracting that lateral and placing provisional denture and restoring the other teeth with the crowns, and now patients planned for an implant on upper left too. However, this is the result you are aiming for after you placed an implant, and patients smiling, because now patient can smile confidently when it comes to doing restorative, and now you have done the predictable restoration in order to make sure that your restoration lasts longer. So these are the few indications of using occlusion in your clinical day-to-day practice. However, when you start assessing occlusion, you will find more and more ways you can implement the principles you learned during occlusion course into your general dental practice. In the next video, we will discuss briefly how you can apply knowledge of occlusion in doing more advanced dentistry.